We're going to start our webinar now. I'd like to particularly welcome practicing nursing home social service staff and social workers, as well as anybody who is working in the nursing home setting. And I'd like to thank you for the important work that you do day in and day out to make a life better for our nursing home residents and their family members. I'd like to also acknowledge the Retirement Research Foundation for their generous financial support of this webinar series. We have at least 2 webinars per month as part of this series. Our days are Tuesday or Thursday, and so the Tuesday webinars usually are presented by social workers and about nursing home best practice in the role of a social worker or social service person. Our Thursday issues are also very germane to the nursing home setting, but they're more of a background information, and often we have non-social workers as speakers as well, because we've got a lot to learn from other professions, but we also have a lot to teach other professions. So anyone is welcome to participate in any of our webinars. They are open to the public, so please share that information if you'd like. You might have during today's session, please type them into the chat box, which is in the lower right-hand side of your screen, and I will be watching the questions throughout. I'm Mercedes Bernklug. I'm here at the University of Iowa, and I'll be watching the chat box for questions that will be posed to the presenter, or if there's any that I can help you during the session, don't hesitate to put something in the chat box. This session is being recorded right now, and the recording will be posted on our website within 24 hours. And those are available free to public as well. In the welcome portion of our webinar today, I'm going to be turning over the microphone to Bob Conley, who's going to actually introduce our topic and our speaker. The speaker is going to present about 55 minutes to the top of the hour, and then we'll open it up for 15 minutes of questions and answers or comments from you, those of you in attendance. So please think of any questions you might have and take advantage of this opportunity to interact with our fabulous speaker. So Bob Conley is going to be introducing our topic and introducing the speaker. He's a social worker, retired from the Center for Medicare and Medicaid Services after about 20 years of experience. And in fact, during that time, he was project officer for the MDS 3.0, so he knows an awful lot about that and the transition to that. And he's the co-leader of this webinar project. So Bob, take it away.
Okay, thanks, Merce. I'd like to say in advance that I'm very honored to introduce June. I first met her in the early 80s when we were both doing hospital social work directing, and that she is a social worker who has stayed in the field and created incredible programs based on both her social work, her public health, her clinical, her knowledge of business, and she's expanded the Partners Care Foundation to be one of the leading innovative programs for community and home-based organizations in the Los Angeles and nationally. Her topic today is really the topic that we want you to be thinking about, because there are emerging issues that are affecting your residents and will be roles that you as social workers will need to have some expertise, and they're really going to grow over time. She's going to talk about dual eligible initiatives, that's Medicaid, Medicare eligible, coordinated care transition programs, and affordable care organizations that create models and opportunities for social work. As you can see by her biography, she's done an incredible amount. She's really a leader in bringing forth population healthcare management. You see the words that are part of her vocabulary that need to be part of our vocabulary, looking at patient populations, healthcare delivery, looking at cost effectiveness and outcomes and reintegrating care. She's a recognized leader that has been on the National Advisory Council for the National Institute on Aging. She has received numerous awards and grants, and I think we're very lucky to have her today. So, June?
Well, I'm, that's quite an introduction, and Bob has his own tremendous track record leading at the national level. So thank you very much. It is a time of incredible change in healthcare and in America, and so it is exciting to think together about the changes that can improve the quality of for the people we're so concerned about, and to look at the implications for social work practice into the settings where you are and in the settings that interface with you settings as people go through the continuum of care. It's important for us to be connected with social work and other resources as people enter and as people leave your settings. So our objectives today are to look at the Affordable Care Act in terms of how it impacts the people, the parents we're most concerned about, how it impacts social work practice, the whole emerging spotlight on long-term supports and services practice, which your nursing homes are a key portion, housing sites are, and community-based services are growing dramatically. So we want to look together at what are some of the key target populations where social work interventions are gaining traction, are increasing interest to a variety of payers and partners, and to look at some of the central social work strategies and interventions that are emerging in these changing times. So let's see if we've got that. Thank you. So what we're really looking at then is a partnership that, I don't know about you, but for me, the time that long history Bob referred to, how long we've known each other since the 80s, I've had the same interest that medicine would actually look at the whole person, that as they live at what matters to them, and that we would bring community-based services and self-management and medicine together. So if we can then take a look. Whoops, did we skip a slide? No. Okay, so we want to take a look at how spend healthcare dollars in America. You hear about this on news every day. You hear about the deficit, about the impact of entitlements, Medicare spending, what it's going to do. If you look at this graph, the obvious outlier on the far left is the United States, and we basically spend 4 times more than any other the face of the earth, and yet our outcomes, our health outcomes, are worse. We're ranked 27th in our health outcomes and number 1 in spending. That is a source of frustration for many people. We would like, sure, to spend less, but we would mainly like to have better health outcomes. So across the lifespan, that's an issue. Certainly in older populations, as you will see, this thing is impacted. It's a move from what we call moving from volume to value in overall context of healthcare spending. And here is a very mature model. It's been around for a couple of decades. It's by Ed Wagner in the state of Washington. That says really we need to look at the whole person, their environment, they care for themselves, how others care for them beyond medicine, how people live, looking at supportive environments, healthy public policy, self-management, how people actually live day to day when they're not in a facility, but also in a facility. In a nursing home, for example, if people won't up and won't engage with others or won't eat their food or won't take their meds. Obviously, it impacts their health outcomes. In an unsupervised setting at home, they have even more freedom, less observation to report that they're getting into behaviors that can harm their health. So we want to build this kind of a fully integrated delivery system. This has been in the works, in the vision of many for a long time, but now it's moving towards public policy, and you can see that for Medicare and Medicaid, innovation has a vision that is moving over time that suggests that our evolution needs to be towards in that same kind of direction, moving from acute health system where we just deal with full interventions to coordinated care and accountable care systems such as we're seeing emerge now, and the increasing case management that, for good or ill in both cases, I guess it's been has been growing to now moving towards the integrated healthcare system 3.0. And see at the bottom areas that really draw the natural social work perspective that we also saw in the Wagner chronic care model on the slide. So we're looking now, we're hearing talk, we're seeing movement towards looking across whole populations, look at population-based health outcomes rather than waiting till people are the Jaspers coming in for care, and when they're in real big trouble, we'll spend endless amounts of money. Now we're going to try to have strategies that focus on keeping people well, improving quality of life early on, and allocating our health resources differently and looking at care system integration with community health resources. So that's an area I want to have you think about today as we look at what used to be comfortably silos of care, different sectors working independently, patients in the hospital, then they pop over to nursing home, they bout to home from either of those sites without a real bridge between them to make a smooth care transition. Now we want to really have integrated delivery systems where people can move smoothly from place to place and continue to have the best possible health outcomes as they go. Now, people speculate that the healthcare investment in America is relatively less than other countries, even though we said at the beginning we spend more than anybody else. But if you look at this where the United States is circled, the blue dollars are health service expenditures, but the red dollars are social service expenditures, and you see that we are way out of whack. We spend endless dollars on medicine, very little on social work. So I'm sure you join me in a passion to us rebalance that in a better way so that we're investing differentially in health outcomes by reallocating the money that goes into medical care into a broader person-centered, more holistic view of how to achieve health outcomes. This, which was not done by a social worker, by a health researcher in 2005, it's not new information, is gaining attention now as we look at what is the cause of a country that seems to have the wrong care in the wrong place at the right time, and how do we move our system to assuring that we're getting the right kind of care to the right people in the right place, the right setting, at the right time. So let's see if we can move forward to the next slide. So to do that, if we think about population health management, it's hard to think about a whole community as a whole community. Obviously, you have to segment it because different groups need different things. Same with social work practice. So here is a way that both healthcare and social work can align to stratify populations, and we're mostly focusing on adults here. I'm not a pediatric specialist, but you can see the largest population is the people who are well. That's who they're trying to wildly to have sign up for Obamacare, which we hope we will encourage them to do. We want them to get in there and have prevention and stay well. They have a significant percentage of our population, and we'll look at some numbers that have chronic conditions with mild symptoms. So people who just have maybe a little elevated hypertension, or they're a little bit overweight, or they're pre-diabetic. And then into more serious concerns, and these are the ones we want to prevent by intervening at the bottom of the pyramid, looking at chronic conditions with mild functional or cognitive impairment. And this top half of the pyramid is where we begin to see that we spend a lot of money, but it's kind of late, and it would be good to keep people out of these zones. And remember, modifiable risk factors, personal behaviors that lead to health outcomes, and environmental circumstances. These are classic social work environments where we can make a difference. You see your nursing home zone there in the complex chronic illnesses with major impairment and end of life. These top two are long-term supports and services zones, and those are people that we're really concerned that we're spending a lot, and could we have made a difference in that? So we want to target our services to the stratification of the population. So on the bottom, if we're looking at older people, the senior centers do a lot with people who are well, and so do recreation and parks and other kinds of congregate settings, looking at food and staying connected and moving around, exercise being the most critical thing can do for health. Then looking at really targeting people who are beginning to have an early chronic condition. There are a host of evidence-based programs which are listed on the Administration on Aging and the National Council on Aging websites and are being spread throughout many states. And these are programs you could adopt in your facilities or encourage in your community. Then as people get caught into the delivery system in institutional care, hospitals, nursing homes, assisted housing sites, we start, and staying at home with long-term supports and services. Now we start to see the importance of coaching for patient activation, for getting food to people, for connecting people with self-management classes, either as caregivers or as individuals for self-care. Then the Medicaid waivers, the long-term supports and services, moving people who come into nursing homes at nursing homes without overdoing their bouncing back between hospital and nursing home, getting safely home from there, and then obviously home care and hospice become very important sites. Or another social work roles for us in each of these segments, and they're changing and evolving and as we go. Bob said one of the big areas of health reform is the dual eligible demonstrations, and they are not only population we're interested in, but for this discussion we're talking mostly about Medicare, and then the dually eligible who are both Medicare and Medicaid are very high risk. More medical services than other Medicare beneficiaries, and we can look at these charts and we can see on the right that people with Medicare only just cost a lot less than the people in the blue columns. They're only look at them compared to the red columns where they are both low income and care, so either disabled or aging. So these complex populations are concerning the nation as a spending group, and they concern us as a group with suffering that's avoidable, where we can make a difference in quality of life. You see on the left side the disparities that lead to these differential spendings. Is it just that they're sicker, or is there something we could do to keep them in better shape? You can see there's a disproportionate use of the emergency room. Now, we know with the Medicaid waivers, sometimes people don't use the emergency room so much that they have access to a more sensible resource that doesn't them straight to the ER by calling 911. With disproportionate use in the second line there of hospital, we need twice as much home health use, and see almost 2.5 times more skilled nursing home use. So these are very important populations across these settings, and obviously a very important population for your practice. Oh, 2 there. There we go. One of the things that's been getting a lot of attention lately that is a big arena for social work practice is the avoidance of hospitalization, just for duals, because the Care Transitions program is for fee-for-service Medicare, so it's a really important population. But the duals, as we know, may be fee-for-service Medicare, but they are, in many states, they're moving into a test integrating Medicare and Medicaid dollars into the dually eligible demonstrations. And the thought is, especially important for this presentation, to look at how to reduce long-term nursing home use. So we see also a big effort to reduce the use of hospitalization. Then you see the potentially avoidable hospitalizations for the duals here at 40%. Now, there's a lot of work I'm sure you're reading about to reduce that. And probably you know that Medicare patients as a whole who are admitted to an acute care hospital have 20% of them are readmitted to that hospital within 30 days. And a good percentage of those are avoidable. So, of course, we want to avoid admissions to the hospital, but we really want to catch the high-risk people who are being admitted. We know that of the 20% who are readmitted to the hospital, we know that readmissions in hospitals, those rates, about 30% of them, at least in our community, are mostly nursing home and also home health. So look at some models that are being adopted to address how to reduce readmissions to the hospital in general when people go home. But at the same time, CMS is paying for that. They are paying for people who leave the hospital and go for a short nursing home stay to then be followed out of the nursing home to their home to stabilize within that 30 days post-nursing home. And then we're looking at how do we just avoid people from going straight back from the nursing home to the hospital. So that's clear. In any case, we're saying sometimes institutional care is really the right place, and sometimes it's really better if people are able to remain at home as long as they don't get too isolated or too endangered in various ways. So to put this in context, because we were talking earlier about targeting, we stratify the population. We want to add new interventions that increase expenditures on social services and other environmental supports. We're going to want to do that where it's going to actually improve lives and save money. So we're going to target, or some people don't like that word in our current world. So let's think about selecting groups with special needs and most promise of a positive result from the investment of new resources. So they want to look at who's using most of our money. The duals are 18% of the population, use 40% of the resources. But if you look, you will see in our country this amazing fact that actually only 5% of our entire United States population accounts for 50% of our health care dollar expenditures. And 1% account for 21% of our health care expenditures. Obviously, we would like to look at who's in those populations. The 5%, about half of them, are people who in and leave. They don't stay in the 5%. They're indigent 5%ers. They have their heart, Cheney had his heart replaced, and then he goes off and he's healthy. He's not in the 5% anymore. But some people are 5%, and we'll look at who they are. So this is very important in terms of where do we spend our time and our money in order to improve lives the most and get the best use of our health care dollar. There's a concentration of risk. We just want to look at it because as workers, these are our people with functional limitations, dementia, frailty, some serious illnesses of special concern. So and chronic disease, accounts for 84% of the health dollar expenditures in America. So I want to address chronic disease at various stages. So in terms of dying, a huge percentage of people dying in America, chronic diseases like diabetes, hypertension, end-stage renal disease, congestive heart failure. Obviously, these are major chronic conditions that progress. Others might be Parkinson's, MS, ALS. But chronic diseases affect quality of life before someone just dies of them. They are a big impact on quality of life, and they're particularly prevalent for older people. So if someone's over 65, there's practically 90% of them that have at least one chronic condition, which most typically is arthritis. It doesn't sound that big, but it's painful. So this is a very important issue, and people just sit and come to the pain, have more pain, and those who can learn to move around and manage it and handle their diet and their meds do better. 67% of those 65 and over have two or more chronic conditions, so we'll see that's really important in terms of how we're using our health care dollars and where we want to concentrate social work interventions. The boomers is really, as probably most of you are boomers, there's going to be a huge impact. We're already seeing it because people have become more active, which should. That's helpful, but now we see a lot of knee replacement, hip replacements. And the obesity epidemic and the diabetes epidemic. So we know that these are coming unless we do something dramatic to help people manage these. And there are dramatic results that can be obtained through better medical management, but largely through things like more who, with diabetes patients, if they have a foot injury, instead of seeing them once in the office and treating the foot, saying change your dressing every day and come back in 2 weeks, they send a car. They pick them up, bring them in every 2 days, and change the dressing themselves, and reduce the frequency of amputation by 60%. Wonderful outcome. Think of the suffering prevented and think of the dollars saved. So these are really important. So diabetes, obesity, arthritis, really important problems for us to target. Find again, if we think, okay, who's really creating having the problem? It's people. This is Medicare. Who's in the top 5%? You'll see in the top 5%, 0% have no chronic conditions. All of them have at least or two, but a third have 3 or more chronic conditions. So they have, you've heard the litany of woes. They've got a hypertension, and they've got chronic pain, and they've got, some other kind of, you hear them in case rounds all the time. But look at that, 61% have both chronic conditions and functional limitations. So when you're in a nursing home, you are seeing a lot of the top 5%. Some are seeing long-term, some of them you're seeing short-term. And so you want to really look at how can you optimize their days if they're long-term, and how can you optimize their safe return to the community if short-term. Now, dementia is really huge, and again, this is a natural to your population. Just take a look at this number, $215 billion a year, but look at how expensive it is compared to other conditions. Disease, only $102 billion, less than half as much. In cancer, only $77 billion. So we could see that dementia is a gigantic impact chronic condition. And it anticipated that this is going to be skyrocketing moving forward. Obviously, this is important for us. It's important because of where they'll be, but also because we need to support their caregivers who bear the brunt of this problem as well. So good caregiver skills and caregiver support, very, very important. You see, with dementia, there's your nursing home population right at the top of the chart. And then, of course, with Medicaid as well. But also the dementia patients have very disproportionate use of the hospital and home health and quite a bit of transition support. So these are populations we want to master. How to prevent. Don't forget that physical activity for you and me helps to reduce the incidence of dementia in the later years. So very important for us to eat right, take good care of ourselves, and keep moving. Physical activity, number one. We see, as you can see, a gigantic increase in the anticipation of the size of dementia populations, and that's going to have a big impact on keeping our nursing homes full. The other factors that are trying to empty the nursing homes, as we know, so this will be really important combination of factors that make it so hard to predict what practice settings are going to look like in the future. So because of this concentration of risk and spending, home and community care principles in nursing home practices for social workers are really, really central to improving quality of life for the people we care for, both the patients and their families, and reducing costs, looking at how we really spend the health dollar in America. So new social work had so much effect on the national budget, but it does. No surprise. Nursing home, long-term supports and services, and home and community-based services are of very high value. So staying is concordant with people's, and yet when they come to the nursing home, some of them get caught in there who could back home. We have to look at new housing alternatives for people, or you become their new home. And need to really look at some of the new models that are emerging to make the nursing home setting more home-like, more patient-centered, more self-directed, more customized. But there's a big move to seek to prevent nursing home placement through the use of home and community-based long-term care services, nursing home diversion, if you will, and subsequent to that, there's talk about trying to take some people who are in the nursing home and see if they can be moved back to the community. Given the growth of the population, you should still be full. So there is a big eye on how do we use that nursing home, who should be in it and who shouldn't. So then to look at this highest risk, highest cost population that is appropriate for social work support, those with functional limitations, frailty, cognitive impairment, serious illness. And we as social workers need to think up for ourselves a fully integrated service line that also addresses trying to keep people out of the top 5%, or if they're in it, how to move them out of it, where our interventions can have effect. And this is going to make us more powerful. This statement in how care dollars are spent. Social work has not exactly been at the top of the let's spend our money on that list as we saw in the earlier slide, at least not in America. Very important. So let's talk about reconceptualizing some of this geriatric social work specialty into new kinds of product lines. So that's what this looks at. On the left, you see we want to look at the proven evidence-based management programs that help people figure out how better to handle some key issues we've just talked about, the chronic conditions, the caregiver issues, risk of falls, managing some of the most debilitating diabetes, of course, leads to heart disease and end-stage renal chronic pain. These are important areas for us. They can be offered in your settings or around your settings. Then things we do that have not been drawn on as fully as they should be, assessments, just the ability to have a full understanding of the whole person and family, an understanding of their environment if they're still in the community, very, very important. And then looking at care coordination, both short-term and long-term, and coaching to help people develop skills in navigating and appropriately utilizing the healthcare resources so they themselves drive themselves to right care, right piece of time. See these various kinds of evidence-based programs that are really nothing new on the face of the earth, but they're going to spread. Care transitions is more new. CMS paying for that. There's 101 sites across the country with competing hospitals working as a community, looking at reducing readmissions and starting to reach out, as you'll see a little later, and working with home health agencies and working with the most frequently utilized nursing homes, really building different kinds of partnerships and tracking results. Now they're punishing hospitals with penalties for too high a readmit rate, but I just read this week that CMS is now talking about doing exactly the same thing to nursing homes who have too high a readmit rate. Because it is a full third of the issue. So we'll look at why and what can help with that, but you can help with that. So you see these are a bunch of interventions in the area of bringing to work assessments and our care coordination into home settings, because medicine does a lot in hospitals, they do a lot in nursing homes, a lot in the front care and doctor's office, but the in-home site is place social work expertise really is both, and the unique expertise that we bring. And this column is really saying we have to look at the way we deliver services. We're building new delivery systems that will have agencies work across communities, just as we're asking competing hospitals to work together. We want social work agencies not to compete, but to build regional delivery systems. So there's a lot of work going on, and certainly we're doing some of it to try to work beyond our regular day and our regular setting to connect with where people come in from and where they go back to, and how we hook all of that up to help people have the most comfort and the health outcomes. Community-based services then now becomes recognized more, even though it's an old, it's recognized as a specialty practice expertise, that it's evidence-based, the home assessment and supports and caregiver skill and support are critical. And you will, depending on your population, you may or may not do a lot with the evidence-based management programs for patients. You may do more with caregivers, but I don't know, let's see, let's go back to that prior slide for a moment. And see on the left, caregiver, powerful tools for caregivers, and the early memory loss program. Those are all programs to help families who are dealing with memory loss and to enhance their skills in caring for frail and frail people and people with dementia at home. So what is self-management anyway? You'll see here it is a whole range of things that people deal with, medications, how do they take them, problem solving, family support, understanding their emotions, how they eat. There's a host of actions that individuals who have chronic conditions must do in order to live a healthy life. Not very different to avoid a chronic condition than they are to manage a chronic condition. So you and I think about how well can we do and what's the best way to stay good as long as possible. There's a program that comes out of Stanford called the Healthier Living or Chronic Disease Self-Management Program. That's why we call it Healthier Living. It's a better name. That's really the gold standard, and there's a whole portfolio of programs that come out of Stanford that address specific populations. It's spread across 47 states. It's in 20 other countries, in many languages, and it's all led by peers. And so it does not require a health professional to do this. In fact, it's preferred that it's not, that it's really a layman-led program with a high degree of structure and training. But our role is to help facilitate and spread these. So all across America, we see settings that are spreading these programs and embedding them in a range of things. And your setting could be one that could adopt it. You could call local area agency on aging and say, either our families need these programs, or we'd like to open our facility so others in the community could come in and get to know us and get this help. Here's a whole menu of kinds of programs that are available. You might also be interested in the PEARLS program under depression management, or the ideas, or healthy moves under physical activity, because those are all for people who are homebound or very frail, and they're very, very careful based programs that can help people. They say healthy moves to move around, healthy ideas and to address depression. So there's many, and they are really exciting to do. And even if you didn't do them, one of the big challenges now is to help people know these resources are available and them to use them so that they can get the benefit. And people, once they do them, they love them. It's just getting them to do it. Getting people to sign up for a 6-week group program that takes 2.5 hours a week is a big deal. So, but when they do it, they get dramatic changes in their lives. They get less pain, more energy, better use of health services. So we hope you'll support them. So many new public and private models emerging. As you can see, CMS testing many new ways of saying how to keep people and how to care for them when they're not. And readmission, especially with the readmission penalties, now in hospitals in the second year and the going move to nursing homes. So we all need to look at what happens to people when they leave an institutional setting and go back home. And how can we keep them from bouncing around? How can we catch changes in condition early, which is one of the critical pieces, and so that we can do something other than wait too long and call 911. 911 is a solution for something totally shocking and unanticipated, or waiting too long and not being able to go to a lesser level of care. So we want to really look at transitions programs and really starting to build them to work with homes, working with 3 of the transitions, or the CCTP communities, as CMS calls them, trying to reduce readmissions by 20% for all readmissions over a 2-year period. And you have 30% of that opportunity. So they're starting to follow patients from acute settings to nursing homes and rely on a partnership with a nursing home to move them out. So this is important to engage patients and their caregivers that have chronic illness and are coming out of institute settings and going to independent settings to be followed post-discharge, to look at their medications, look at do they have food, do they have an appointment for follow-up care with their doctor, do they have transportation to get there, do they know how to manage their meds and report their meds. 72% of readmits come from medications issues. So top 2 causes are being in the nursing homes and having meds issues in the nursing home or at home that ideally managed. So the transition programs are really trying to jump on top of how to get better results by identifying people at risk. So remember, we talked about targeting or stratifying. So In the case of a hospital, we're working with UCLA, for example, for Medicare patients who have both A and B, fee-for-service Medicare, and are not hospice. And we look to see who's been in the ER, who's been in the hospital recently, who has early signs of cognitive decline, an overwhelmed caregiver, more than 2 meds changed while in the hospital, 3 or more chronic conditions, a whole host of things like this. It's not diagnostically based. It's looking for people who are at risk of readmission. And it calls on them in the hospital. If they go to nursing home, they call on them in the nursing home. Introduce themselves and try to engage people to be able to then be visited at home. It's not easy to reach people at home. But they will come doesn't always work, so we find that even though we build these programs, people, maybe we don't even know where they are. So one of the things you can do if people are leaving your facility is that hospitals can really figure out where they're going, what's the phone number there, backup way to reach them, because a lot of times it's just you can't find patients who have left an institution. It's a surprisingly high issue. People are just too tired or just are afraid. They don't want someone in the home. Sometimes families want to put patients themselves and block access. There are lots of cultural issues, linguistic issues. It's very important to look at the challenges and to partner together with people who are inside the hospital and the nursing home and people who are doing the home visit through the Coleman intervention, the Coleman Care Transition Intervention. A social worker or a health coach on social work supervision. So, as described, it's people who've been in the hospital. They need to be seen immediately after discharge. In home, then they have get a meds list together. They learn how to recognize changes in condition. They structure that follow up with medical care. Make someone can get there and make sure they have. So it's very, very important components. And then you, I think, also recently heard about the Bridge Transitions program, so we'll mention that. But I know Robin gave you an excellent talk, or if you didn't hear that, I'm sure it's posted with this presentations. In case we have an evidence-based program called Home Meds that we love to see people adopt, and it's available for people to adopt in their communities. And because meds are so important, but the nice thing about this is it's a social work program. We've developed and researched with random controlled trials with credible researchers, built the software so the social worker is a terrific detective to go to the home, figure out what's really being taken and not being taken, sort through the whole house and see what's really there, talk with people about how they're taking them, and also take a look at the over-the-counters and herbals and supplements that people have, and the level of problems with medications with people, even people in coordinated managed care medical things. We did one recently, and after the home review and interviewing the patient to see are there signs of adverse drug events, like is there confusion, is there dizziness, is there a history of recent falls. Those can be looked at with meds to see is it the person declining or is it caused by the medication. Then take that to a pharmacist if there are alerts on the software. And 63% of these people coming out of the hospital that we saw after pharmacist review had reportable medications issues that the doctor really needed to know about. So they're like food. They're hard to live with and they're hard to live without. Really, really important. They are an arena of social work practice with evidence-based software support. We really recommend you have a transitions program that's following people home out of your facility. that you look at home meds. It's very affordable. It can be done through your area agency on aging, your Meals on Wheels program, your own selves, whoever's doing your care transition. And then we encourage both nursing homes and hospitals not build just a freestanding care transitions program of their own. We're trying to encourage the development of regional social work delivery programs. So because just in LA, driving is too hard. You don't want people driving all across town. As you know, people discharged from facilities don't necessarily go next door. They go far away. So we want to have ways of working across agencies with similar interventions, being able to do that. So hospitals think they can build this themselves. Nursing homes may come to the same conclusion, but Molly, we find they don't want to drive more than 3 miles, and their patients come from far and wide. So we develop broad delivery systems that can go where patients are. Overlapping networks and service lines for social work emerging in this dramatic time of change. Evidence-based self-management networks are being built across communities so people can find these programs, and you can look them up through Area Agency on Aging and connect families and people with them. It's findable in your community. The transitions in nursing home diversion networks are important, but then the long-term supports and services, that's optimizing social work practice in the nursing home, really looking at when people do leave the nursing home, which huge numbers, as you know, do. That's not like the hospital used to be, just a cliff, and you say, well, good luck, here's your discharge plan, we hope it works out, but that we really build bridges that help people to safely resettle in their home setting and get stable, get safe, and that's immediate. Now, there are Medicaid waivers probably in your community like ours, so those are programs that are going to be spreading in California. We have limited ones, but under the dual demonstrations, they're going to expand on a private basis with health plans, because under the dual demonstration, the risk for paying for the nursing home goes from the government to the health plan and the patient group. So all of a sudden, the motivation to keep people in nursing home is changed because the funds are all integrated. It used to be, at least if someone was in trouble, the payer could just help support them into a safe and wonderful nursing home setting, and they didn't have to pay anymore. The person might spend down. The government might spend down. The health plan and the physician group were safe. That risk has been moved, moving more and more across the states. So this is going to be a transformational shift of financial responsibility, and we're all going to see it impacting our practice a great deal. So then we see all the things that can keep people at home and keeps them at home for a much lower cost, typically, than the cost of the nursing home. But it does take ongoing care coordination, it takes food, takes a lot of adaptation of the home setting, and so on. We've got some very interesting things that have been developed at Cedars-Sinai out here in Los Angeles, the large private not-for-profit hospital in the country. They have been building partnerships. We see a lot of consolidation in the current healthcare world. I don't know if you read about these things, but bigger and bigger players buying bigger and bigger players. So we see doctors groups being purchased by hospital systems. We saw DaVita, the end-stage renal disease dialysis company, buying a large physician group, Healthcare Partners, for $4 billion. So these are really big. Well, we see the lines of ownership and practice blurring between payers, between hospitals, between nursing homes, between physicians, between home and community-based services. So we're evolving to a really different world. So Cedars-Sinai was looking at admissions. So they did some very interesting things as a hospital. Here's a hospital paying for this. They were not paid by CMS. This is independent innovation on their own. So they looked at their 30-day all-cause readmissions for nursing home and home health. And then it was the university hospital groups. So they looked at, of the people that they discharged to a nursing home, they saw a much higher rate of readmissions, and the same with home health. So they decided this was something they'd like to take on. So they decided they would try to cut that in half. So just think about the implications for nursing homes if hospitals reduce readmissions to the hospital by half. Will they be? They might mean some people won't get a second 3-day stay. They mean some people will get their conditions caught much sooner and be able to rest and thrive in the nursing home. They might mean that people will continue to recover and stabilize, be able to go home at greater frequency. So they, in a very active investment, they placed practitioners inside the nursing home at the expense of the hospital, and for their patients that had been discharged there. And, they reduced a readmit rate from the nursing home to the hospital from 25% of the patients going back within the first 30 days, which does seem high, to 11%. And with home health agencies, they had another intervention, and they cut the rate in half. So you can see that can do a better job of caring for people because, of course, the patient comes to the nursing home and stabilize, they settle in. That is better than if they get sick, you have to call 911 in the dark of night and rush them back to the hospital. So how we do that. So they looked at what are the root causes for nursing home readmissions. We identify these risks and manage them. Doctor coming around enough or an advanced practice nurse seen by a doctor within the first week of discharge. The nursing home staff don't have a good way to reach the doctor for timely support when they see a change in condition. The patient of the family isn't alerting the nursing home staff that there's some changes that they're observing since they know the patient best. Weekends are a very active time for readmissions, it turns out, when there are fewer eyes and ears. Meds, of course. Let's say the hospital sends patient to your nursing home that they don't tell you in advance what their pain med is and you don't have the formula, and they come on Friday afternoon. The patient develops extreme pain, avoidable pain, because it wasn't communicated properly. So, and then of course the advance directives and post. So we, a lot of things that we can influence in some ways. So CDERS put nurse practitioners inside the 6 or 7 nursing homes they had identified. They saw the patient in the hospital, then they saw the person in the nursing home 24 hours after discharge, followed them once or twice a week, and whenever they saw something changing, they asked for help from the nursing home. So very basic, some of these are kind of like simple things. And they got those good results on a 5-day week, but when they went to a 7-day week, they significantly improved their results. So weekends are really an important time to watch. Home health, just very, very quickly, because I know we're almost out of time. They basically targeted selected home health agencies and had them sure to see the patient at home right away, because sometimes home health agencies are slow to get out there, really their meds, and home agencies are paid on a bundled basis. They get a rate for an episode of care, so they have them to intensify it at the beginning. See them within 24 hours, give a Friday night tuck-in, multiple calls, very available at the call center to see them anytime they need help right away, especially during the first 10 days, and they had dramatic results in reducing readmissions. So if you pay attention and you're very responsive, look at this. You see they went from 25% to 10 or 12% readmissions. So cut it way down, which means they cut human suffering way, way down. That nurse also visits. It seems for all these programs, seeing the person in the hospital is important, and then following them timely is important. And look, by the end of this, they had reduced readmissions from home health by 2/3. So really dramatic. So readmissions can be prevented, and you have a big role in this because your things are really dramatic contributors. And it has to do with listening to patients and families, making sure that your system responds to them, and getting them followed out into the community after review, looking ahead for their discharge much more intensively, and assuring that the plans actually get implemented by the people who pick them up. So integrating instead of referring. They're changing times, real big opportunities for us to really improve lives, to really smooth out the care and things that cause a lot of avoidable suffering and a lot of cost. By following patients across the continuum, by connecting sites of care, by building relationships between providers of care, by, and I say this, articulating the value of social work. It requires us to translate because people don't, so often, as you know, they just don't get it, what we do. And we do it so important, and it is becoming more and more important as we see how crucial it is to look at results early on and really be responsive to people, to help people call out for help sooner, to give them the help they need. So for us, I think a lot of persistence is required because we really have an opportunity now both to expand the number of lives we touch and how we touch them, but also just to advocate for the quality of life for the people we dedicate our lives to. That's my presentation. I hope it was of interest and value for you. If you want it, it's on our website, as well as other information materials and presentations along the line. And I certainly would welcome any questions if you have some. Otherwise, I thank you so much for your kind attention and hope that this was a valuable use of your time.
June, fabulous information and very well packaged to be able to consume all these big changes and what it can mean and what it is meaning for social work. If anybody would like to type in a question in the chat box, that would be helpful, and then we'll read your questions. Bob, I'm assuming your phone is unmuted in case you'd like to say anything. Also, June, I was completely blown away by the huge opportunity that is presenting itself for improving patient care and resident care. We're finally getting some of the financial incentives in line with what sounds to be really good care from a patient's or resident's perspective. So do you feel that all these kind of financial changes will result in better care?
That they have to, because they're carrot and stick. So they're punishing with penalties, increasing penalties from year for the health outcomes on a payment basis. So a hospital that has too many readmissions and later a nursing home, the Medicare reimbursement is diminished for doing a bad job. On the other hand, can hold their own and therefore be better paid than their peers. So there's a lot of opportunity in that regard. And then there's a big interest in sharing savings. So now there's the accountable care organizations and the dual demonstrations and Medicare Advantage. All these kinds of programs are looking at what is the best package of services to help people stay in the best possible health care and use only the appropriate medical services and not inappropriately end up in ERs and hospitals and ICUs and so on. So end-of-life care, advanced directives, and keeping people well at the front end. Yeah, these are all big opportunities, and they all incorporate a lot more of our kinds of services and approaches.
I did get a couple people who wrote in and said, thank you, very good information. So people are very happy with having heard what you had to say today. I'm going to encourage people to re-listen to this with somebody else from your facility, with the director of nursing, with the administrator, and think about what you could do in your nursing home to anticipate these changes and to get ahead of them and figure out how to provide some leadership in your community that can benefit your residents and your potential future residents. So often I hear nursing home social workers talking about not being able to do social work, that they're being deployed to do a lot of other kinds of activities that aren't related to psychosocial issues or communication.
Right.
I think you're making the case loud and strong that those skills and that art that social workers have is really going to be valued in a way that it has not been in the past. It's going to be incumbent upon the practicing social worker to articulate what she or he is prepared to do, educationally prepared and experienced prepared to do in light of these new challenges and the new expectations for healthcare settings.
Absolutely.
June, I thought you did a great job, and I guess the thinking that really came to me, thinking of where nursing home is, that it's often a host setting, always reporting to social work, but nursing or other disciplines. And the big thing that having worked nationally is how do we have some data that can capture, like the Stanford model does, or the Coleman model does, or even the Rob Goldman.
Right.
We do. How do you do that in a home care setting with your staff to get these grants and to show how you can be a leader? Do you have extensive data, or are you taking the vital few information, kind of like in your med model where you were saying they look at meds and scour the house, or as you said, with that nurse practitioner program where they tuck them in? How do you convey both a data and a psychosocial way the views of this kind of care? Because I think it's often missed.
Yeah, that's why I think we have to talk and we have to person, and then probably we also need to have partners. We need champions, and they need to be nurses and physicians who a lot of them absolutely share these values and can take me around those niche interventions. Where Coleman's a physician, he invented the Coleman intervention for care transitions, which was applied to hospitals, but now is going to be applied to nursing homes. The minute the nursing home learns that they're at risk of penalties or rate or too many readmissions, or the minute the hospitals in their community tell them we're going to transfer patients differentially, and nursing homes have high admit rates are going to be punished by having lower volume, business case will be made. And if the work is there to bring evidence-based supports, then I think that, if they can, for instance, help families learn to identify and report timely changes in condition, if they can help address depression in patients, which some of these interventions do, if they can help build nursing home interventions that help people bridge from nursing home to home and stabilize there as they do from hospital. They have some nice product packages they can pick up. But look for other voices, little voices in the wilderness. We need to speak as groups. We need to work with our area agencies on aging. We need to find our physician and nursing friends who drunk the Kool-Aid and are able to articulate these things from a position of greater power and recognition than we may have.
And will payment that the plan or the provider group will be responsible for the missed handoffs and that kind of thing? Is that part of the Affordable Care Act? Is that a payment issue? Is that part of your Medicaid dual eligible? Kind of how is that going to be?
Well, there's several ways. Under the dual eligibles, then the nursing home expense moves under the health plan and who is carrying risk for that population. So that changes their motivation completely. But short of that, anybody who is the payer for the hospital going to be the party that's willing to make investments to avoid inappropriate and excess use of the hospital. So that's the health plan, but it may be a physician group that's at risk. In California, we have a lot of physician groups that carry risk, and they are impacted by the cost of the hospital, and they're very careful to try to make sure hospital use is appropriate. Once they're under the dual, they'll do the same with the nursing home. And the penalties, once the nursing home starts having penalties, and think of them as twofold. Whoever's paying it? If patients are going to the hospital too often and the hospital's going to get dinged, they're going to frown on that. They do not want that penalty hitting them. And so they are going to look to providers that will be able to keep patients safe and stable in nursing home and then get them home safely after if they are short-termers. So who's paying? It's not really a uniform answer. There are many, many ways that shared savings around these issues are being modified under the Affordable Care Act.
When you were talking about how risky it is on weekends for the hospital readmissions, and I can't help but wonder if it might be time to reconsider working hours for nursing home social workers. That if we're going to be working even more with families, maybe we need to be there when the families are there, and that is often in the evenings and it's on weekends. And
True.
so, and I know that I'm not expecting social workers to be working 12 and 14 hours a day, 7 days a week, but you may want to use some of the information presented today to negotiate to have another time person hired, or to do some job sharing so that there's more than one trained nursing home social worker available, and that the times are covered more than your 8 to 5, 8 to 4, Monday through Friday, and really reach out to when families are there and at these high-risk times.
Yeah, good point. Yeah, it does impact the whole design of how we deliver services. And how do families reach us? Are we used up doing other things, or we're not available at the right time? That's a great observation. I love that.
Your point also about the home meds program and all the consequences of patients going home and not understanding their medication regimen and the importance of strong follow-through with that. I think a lot of our social workers can relate to that as well. Just that follow-through, that important follow-through, especially right before, right during, and right after the transition, just making sure that the resident and the family have the information and the support that they need to ease that transition. So,
it's true. And, we do have someone who leads that program. If you're looking down the road, you may want to look at how do nursing home social workers participate in discharge planning, and do they have care transitions linkages they make, but also they should just learn about the home meds program. It's very interesting. It's very social work based, and it does give you a different view of what we're capable of as a discipline. Think of us as managing meds, and we like to use that and management of chronic pain group as evidence that we actually impact health outcomes. Our mantra is social work directly impacts health outcomes and therefore health service use, and therefore we're an important investment.
Well said, and those are wonderful words to conclude this webinar. Thank you so much, June, for giving us kind of a bird's eye view of many, many changes that are currently underway and helping us re-envision the role of social workers and help get ready to really be part of these exciting changes that are going to present challenges, but are also good opportunities to improve the care for the people we work with. Thank you so much.
Well, thank you. Take care.
Goodbye.
Bye-bye.